Alright, hi guys. So let's start the recall of FMG, and right now we are going to discuss June 2022. Now this recall that we are going to discuss is one of the most authentic recall, and I would say that we have put a lot of time and effort from collecting the data from the students usually, and it has taken a lot of time, and definitely you guys are going to enjoy this FMG June 2022 recall. So let us see the very first question that was asked in this. A patient undergoing spinal surgery developed a very high blood pressure. See, very high blood pressure, 240 over 120. Which of the following drug is not used? So they are mainly talking about high blood pressure, so hypertensive urgency like scenario. However, if there is end organ damage, we can also call it as hypertensive emergency. So the drug of choice for hypertensive emergency like scenario, it is going to be IV nicardipine. We can use other drugs as well like esmolol, hydralazine, nitroprusside. But what is the use of mannitol here? Mannitol, as I have already told you in one of the previous explanation, used for treatment of intraocular pressure, intracranial pressure, and also can be used in the dialysis disequilibrium syndrome. Okay. So mannitol is of not use here, right? It's of less use here. So IV mannitol is an osmotic diuretic, as I've told you already, for the glaucoma, cerebral edema, and dialysis disequilibrium syndrome. Since dialysis disequilibrium syndrome was discussed here, just immediately after June 2022, the next INICT examination, they directly give the scenario: a patient was undergoing dialysis and now he is having this kind of problem, confusion, and another problem, and which of the following drug will be used. So they gave a clinical presentation of dialysis disequilibrium syndrome. Coming to this question of hypertensive emergency, the drug of choice, as I told you already, is IV nicardipine because they are the very fast acting. Clevidipine, clinidipine can also be utilized. Hydralazine is a potassium channel opener that can be used. Labetalol, esmolol definitely can be used. Sodium nitroprusside is a second line drug. Phenoldopam is a D1 agonist that can also be utilized. So these are the important drugs that is used in hypertensive emergency. But if the examiner is going to ask you hypertensive emergency in pregnancy, labetalol can be used in general population as well, and they are also utilized as a drug of choice for hypertension and hypertensive emergency in pregnancy. All right. So next question. A patient was found roadside in an unconscious state, pinpoint pupil, heart rate and BP both are low. There is a history of drug addiction. Which drug is most likely he has consumed? Now, pinpoint pupil, whenever you see the pinpoint pupil, you think about few important areas like phenol poisoning, organophosphate and carbamate poisoning, right? And also your morphine poisoning and pontine hemorrhages. Pontine hemorrhage is immediately ruled out. Why? Because there is a history of drug addiction. Okay, and there is no weakness. There is no weakness in the limbs or upper limb, lower limb. There is no weakness mentioned here. There is a pinpoint pupil, heart rate and BP both are lesser. Look at the option. Drugs like cocaine that we have, cocaine, it is one of the selective or norepinephrine reuptake inhibitor, NET inhibitor, norepinephrine transporter inhibitor, and because of that there will be increased sympathetic activity. Because of the excessive sympathetic activity, they inhibit the norepinephrine reuptake. So norepinephrine availability at the synaptic cleft will increase, and because of that excessive sympathetic activity, they will always increase the blood pressure, heart rate, tachycardia will always be there. Amphetamine likewise is also a sympathomimetic drug. Right now, looking at the scenario, pinpoint pupil, decreasing the blood pressure and all, the only option that is fitting to this is morphine. Why not haloperidol? Remember, it's a typical D2 blocker. It's an antipsychotic drug, and they are usually associated with side effect like extrapyramidal symptom, associated with side effect like hyperprolactinemia. I hope it is making sense to all of you guys that haloperidol, worst case scenario, it can be associated with neuroleptic malignant syndrome. Neuroleptic malignant syndrome, but here extrapyramidal symptom hyperprolactinemia will present differently. Neuroleptic malignant syndrome will also present with the high body temperature. There will also be fluctuation in the blood pressure, there will be increase in the myoglobin, increase in the creatinine kinase. That will be neuroleptic malignant syndrome. But here pinpoint people, drug addict, haloperidol is not a drug of addiction. Okay, so immediately ruled out. Morphine can present with all of them. Morphine in the higher doses, remember, it can cause a decrease in the heart rate, decrease in the blood pressure. Morphine can also present to you with constipation, and morphine can also present to you with pinpoint pupil. Remember this one. Okay. So I think the same information that I have told you is pre-written for all of you guys here, just to save some time. The opioid morphine, they can present to you with hypotension, bradycardia, pinpoint pupil, and constipation. Others have been ruled out. Cocaine, amphetamine, they are sympathomimetic drug. They will be presenting to you with excessive sedation, like mydriasis, increase in the blood pressure and all. Okay. A person came to emergency with snake bite 8 hours ago. He has already been given 10 vials of antivenom at the local hospital. Following is the next step if the patient doesn't recover and signs of neuroparalysis. So antivenom has been given. Antivenom will take care of the venom. If the neuroparalysis sign is still there, then in a patient with a snake bite, what do we give? Always and always remember, we try to give a drug known as neostigmine. The problem with the neostigmine is that it is one of the acetylcholine esterase inhibitor. This acetylcholine esterase inhibitor will always and always increase the level of acetylcholine. The level of acetylcholine, when it is high, this acetylcholine will be acting on the areas like nicotinic area and nicotinic ke baad se they will also be acting at the muscarinic area. In the snake bite, which receptor is actually blocked? Neuroparalysis there, right? So mainly which receptor is possibly blocked here? So we can say most likely NM receptors are blocked. That is why the problem is there. When acetylcholine is increased, they will be acting on nicotinic also. That means one of the NM receptor पे भी काम करेगा and muscarinic also. When they increase the muscarinic activity, M1 activity, they will increase the risk of peptic ulcer disease. They can also cause CNS symptom. M2 activity, they will cause decrease in the heart rate. M3 activity, they can cause bronchoconstriction. M3 activity, they can also cause excessive bronchial secretion. Because of the excessive bronchial secretion, they will be having difficulty in breathing as well, right? There will be increased risk of aspiration as well. So see here, you are trying to treat with the neostigmine to make sure that you are treat the neuroparalysis, but the patient will develop some other problems in form of again GI abnormalities, CNS symptom, bronchoconstriction, or excessive secretion, or decrease in the heart rate. So what do we do actually? We try to block these muscarinic receptor, and along with the neostigmine, one drug that mandatorily should be added will be non-selective muscarinic antagonist by the name of atropine. You see, our action snake bite में NM receptor is blocked, so we want our activity at the nicotinic area because nicotinic is further there at the NM as well. We want our activity at nicotinic area. We do not want our activity at the M1, M2, M3. है ना? So what we are going to add is neostigmine and atropine. Let's rule out other option. There is no point of giving aspirin. It's an antiplatelet drug. IV hydrocortisone, it's a steroid. Anticoagulation therapy, there is no point of giving anticoagulation therapy, and we expect that it will improve the neuroparalysis. There is no such history here. So very simple question, and exact options were there. Next question. A patient with long-term history of congestive heart failure and with maintained ejection fraction and no signs of hypervolemia comes to you with the long QRS. There is a cardiac wall hypertrophy. Which of the following drug is best to be started to prolong survival? So simply examiner is asking that which drug can improve the mortality, right? Which drug can reduce the mortality or improve the mortality, right? Reduce the mortality in chronic congestive heart failure. So for decreasing the mortality in a chronic congestive heart failure, the best one that we are having, it is going to be ACE inhibitor. ACE inhibitors are the best one. Others that you can use will be your angiotensin receptor blocker. Then you can use one new class of drug, we call it as the ARNI, where there is a combination of ARB and neprilysin inhibitor. ARB and neprilysin inhibitor. So what is ARB? The ARB that we can use will be valsartan, and sacubitril is a neprilysin inhibitor. So they are also having mortality related benefit. Then beta blocker, low dose beta blocker, they can improve survival, right? Then your spironolactone mainly is an aldosterone receptor antagonist. So they are also having mortality related benefit. They also improve the survival. Now let's read the option. Digoxin, it's the drug that is utilized in congestive heart failure patient with the atrial fibrillation, a very controversial drug. Remember, it's a sodium potassium ATPase inhibitor, and we have no report that it can improve the survival. sodium potassium ATPase inhibitor. ठीक है, the name of the drug is digoxin. Lisinopril is one of the drug that is a ACE inhibitor. ACE inhibitors are the best to prolong the survival. Furosemide is a diuretic. In acute condition to decrease the symptom we can utilize. Again, they have no such report that they can improve the survival. Nifedipine is a drug that will mainly be causing vasodilatation. Any vasodilatation will cause fall in the blood pressure. They can cause reflex tachycardia. In fact, nifedipine is not mainly preferred in this chronic congestive heart failure. So given the scenario that we have, the best option that we are going to see is lisinopril. Lisinopril is the best option in the given scenario, and these are the drugs that can decrease the mortality. And also remember, vasodilator have also shown to have some mortality related benefit. A patient with hyperglycemia and positive ketone bodies. So hyperglycemia, excessive glucose and ketone bodies. As soon as you see ketone bodies, glucose level high, think about none other than diabetic ketoacidosis. Diabetic ketoacidosis में sugar level is so high that in fact your blood or circulation is stopped or it is reduced and it become very sludgy, है ना? It's like a sugar syrup that is flowing in your veins, है ना? So whenever sugar syrup is flowing in your veins, that means the concentration is so high, you will have to increase the hydration. Hydration. That's the first thing. Because of the excessive glucose, the next thing that you can add will be insulin. So diabetic ketoacidosis. Next, which of the following drug therapy is most suitable? So as I told you, the mainly what are you going to take care is fluid, insulin, and there will be electrolyte imbalances as well. So you are supposed to correct the electrolyte imbalance. These are the first three steps that you will immediately check on. Electrolyte imbalance. Okay? Metformin is an oral drug, definitely is a drug of choice for type 2 diabetes mellitus, but not utilized in the acute scenario. Insulin and IV fluid, definitely you are going to see. Potassium chloride, you can use potassium if there is hypokalemia. Ringer lactate, again, it's not the fluid that we will be choosing. Insulin plus IV fluid. So this is the one. This is a case of diabetic ketoacidosis. It's a metabolic disorder characterized by increase in the presence of ketones, development of ketoacidosis and hyperglycemia. Okay? They can also be seen in the deficiency of insulin. So treatment of diabetic ketoacidosis, according to our Goodman-Gilman, they are telling 9% saline infusion, not the ringer lactate, saline infusion, correction of potassium, hypokalemia, IV insulin, and IV soda bicarbonate also can be given, again depending on the electrolyte level, depending on the abnormality in the electrolyte, we can even add these as well. So main three step, always and always remember: fluid, insulin, electrolyte imbalance. LD50, I mean pharma is never complete without general pharma questions. So LD50, it stands for, LD50 is a dose that can create lethality in 50%. So 50% of animal mortality in an experiment after exposure of a drug, 50% effect of the drug in animal sample, death of 50 animal, not 50 animal. It should be 50%. If we are using, let's say, a 30 animal in a experiment and a dose that can kill 50% of the experimental animal after exposure of the drug, that is LD50. So LD50 mainly we use for the calculation of therapeutic index. So therapeutic index is equal to a drug that can create lethality in 50% divided by a drug that can be effective in 50%. LD50 divided by ED50, and mnemonic that I always used to tell you is TILE. Therapeutic index equal to lethal dose divided by the effective dose. Okay? This was an easy one. A tourist has visited an Indian village and developed mild diarrhea, which later on found to be caused by E. coli or normal commensal. Which of the following is the most suitable drug to be used? So again, Indian village, mild diarrhea. So just the mild diarrhea they are mentioning. Just the mild diarrhea. There is no colitis, there is no excessive secretory diarrhea. Simply mild diarrhea. What can you use? So mild diarrhea, usually you can use loperamide. Loperamide, remember, can also be used. It can also be used in chemo-induced diarrhea. And do you know, you'll be surprised to see same kind of question, same kind of option in the next. This was June. In December, December there was no exam. January 2023 FMGE examination, what they did, they change, a patient underwent chemotherapy and he is having this level of diarrhea, which of the following drug will be used? So loperamide, it's a opioid. Opioid will be causing, decrease in the intestinal motility. So opioid can be utilized. So loperamide again was the correct answer. So you can check out even Gen 2023 and you will find the question of chemotherapy induced diarrhea that I'm mentioning. You will find this one. So again, topics are remaining same. Sometimes they change the option a bit, sometimes they change the language of the question and they give the same thing. So everything around this question you should learn. Rifaximin will be used mainly if there is, let's say, colitis like situation, we can use rifaximin. Secretory diarrhea, maybe we can use octreotide, although octreotide is having multiple other uses. Zinc again is an add-on drug. Which of the following statement is incorrect? So about organophosphate and carbamate poisoning, they are asking incorrect statement. Carbamate bind to acetylcholine esterase irreversibly. Okay? So if you are going to look at the acetylcholine esterase enzyme, acetylcholine esterase will have two active site. One of the active site of acetylcholine esterase that we know, it is known as anionic site, and other one is known as your esteric site. So there are two active site, one is known as your anionic site and other one is a esteric site. Now when there is organophosphate poisoning, upon organophosphate poisoning usually they will occupy mainly the esteric site and anionic site is going to be vacant. But when it comes to carbamate poisoning, CB is carbamate, they actually occupy both the site. They occupy this side and they also occupy the esteric site. Both the site will be occupied. Alright. So carbamate bind with the acetylcholine esterase irreversibly. Carbamate and organophosphate, they both will bind with the acetylcholine esterase irreversibly. That's the correct. You have to choose the incorrect. Atropine can be used as an antidote. So definitely for both of them, antidote is atropine. So this itself is a information. Atropine is the antidote of atropine carbamate poisoning because they will again antagonize the symptom that is caused by excessive acetylcholine. Once the acetylcholine esterase site, these are the acetylcholine esterase ka site hai na. Acetylcholine esterase normally cause metabolism of acetylcholine. It inactivates acetylcholine. And when you inhibit acetylcholine esterase or when you make sure that this acetylcholine esterase become inactive, now the level of acetylcholine will increase. Acetylcholine esterase inactivation will lead to increase in the level of acetylcholine that can lead to cholinergic crisis like features. Pralidoxime has its role in reversal of enzyme in carbamate poisoning. See, oximes is a drug like pralidoxime, obidoxime. They mainly bind at anionic site in organophosphate poisoning. So mainly in the organophosphate poisoning only they will be working. They will have no activity in the carbamate poisoning. Why? Because anionic and esteric, both the sites are occupied here. Anionic and esteric, both the sites are occupied. So remember, carbamate poisoning may we will have no or this pralidoxime will not be acting in the carbamate poisoning. Atropine is used as an antidote of carbamate. So again, as an antidote of carbamate, as an antidote of organophosphate, atropine is the drug of choice. Acetylcholine esterase, it's normally an enzyme. For example, if this is the nerve ending, we are having lots of acetylcholine here. They are mainly metabolized or inactivated with the help of enzyme acetylcholine esterase. And when acetylcholine esterase become ineffective or when you inhibit acetylcholine esterase, what will happen? The level of acetylcholine at the synaptic left will increase and they will be causing more and more cholinergic crisis. And organophosphate is one of them that will be binding at the esteric site and carbamate bind at both the sides. So when you give oximes, they mainly act by binding. They need a site to bind. So they will be binding at the anionic site, and after binding at the anionic site, they will bind here at the anionic site. And after binding at the anionic site, they will be forming a phosphodiester complex with this one esteric site. They will form a complex with this one, and after binding, after forming a complex, what they will do? They are going to cause a dissociation. They dissociate from here, right? They dissociate from here, leaving the site, both the site vacant. So if you want to make sure that your organophosphate, acetylcholine esterase enzyme is working, both the catalytic sites should be active. What are the both sides? Anionic and esteric, both the sides should be active. Okay, next one. A 70-year-old Parkinson disease patient suffer from constipation after taking anti-Parkinsonin treatment. Which of the following drug may be responsible for the above symptom? Okay, constipation after taking anti-Parkinsonian drug. So anti-Parkinsonian drug, Parkinson disease में there is a in Parkinson disease there is a degeneration of dopaminergic neuron. ठीक है, degeneration of dopaminergic neuron. Because of this, the outcome will be something like this: that dopamine level is much lesser as compared to acetylcholine. So normally there is a balance between the both, but because of the degeneration, there is level of dopamine is lesser compared to acetylcholine. This is how we see here. Acetylcholine is high. So for the management of the Parkinson disease, what we do, we give a dopamine agonist. And a dopamine agonist we can give levodopa. They will have different kind of side effect. Or you try to bring the level of dopamine up. Dopamine कम है, dopamine के level को बढ़ा दो, or you try to bring the acetylcholine down, or you give centrally acting anticholinergic. Centrally acting anticholinergic. This centrally acting anticholinergic that I am talking here will be having drugs like your benzhexol, benztropine, trihexyphenidyl, है ना, benzhexol, benztropine, trihexyphenidyl, procyclidine. So these are the centrally acting anticholinergic, and if they are anticholinergic, they will never leave their nature. Their nature, anticholinergic drug is to cause blurring of vision. Anticholinergic hai to they can cause dryness, they can cause decrease in the secretion. Anticholinergic hai, so they can also cause constipation, right? Constipation, they can also lead to urine retention. So these are the important side effect of this anticholinergic drug. Which anticholinergic? Centrally acting anticholinergic drug. They are associated with this kind of side effect. I hope it is making sense to all of you guys. And levodopa will have other side effects, like they can cause fall in the blood pressure, and they can even lead to in high doses they can even lead to other problems like increase in the blood pressure, and they will have problems like in the eyes, and among the given choices, which drug will be responsible for the constipation? That is going to be your benztropine. This is the centrally acting anticholinergic drug. Levodopa is definitely the drug of choice for Parkinson disease in this patient, 70-year-old patient hai na. Pramipexole ropinirole. What is pramipexole ropinirole? है ना, pramipexole ropinirole. It is also one of the drug that is dopamine receptor agonist, non-ergot dopamine receptor agonist. Metoclopramide is a D2 blocker. It's a D2 blocker. It will precipitate Parkinson disease. Already dopamine level is high in this one. So correct answer for this one is benztropine, because they are the centrally acting anticholinergic drug, and these are associated with side effects like blurring of vision, secretion reduction, dryness of mouth, urine retention, constipation and all. Drug combination preferred for medical termination of pregnancy, and I think this question has been asked a couple of times as well. So we always try to use misoprostol, one of the prostaglandin analog. In addition to this, anti-progesterone like mifepristone, which is also given the name as the RU486. Misoprostol, mifepristone, these are the one. Lubiprostone, it's one of the drug that is utilized for improving intestine secretion level, to improvise the intestine secretion level. Lubiprostone, right? L-prostadil, it's also one of the PGE1 analog. L-prostadil is a PGE1 analog that is mainly given L-prostadil for erectile dysfunction. So which two combination? Mifepristone and misoprostol. So again, same information has been taken from the book. The preferred is mifepristone, misoprostol. Mifepristone is anti-progestin that I told you already, in combination with misoprostol and other PG like dinoprostone, a PGE2 analog that can also be utilized. All right, when mifepristone is used to produce medical abortion, that is MTP, first trimester pregnancy, it is given 48 hours after the anti-progestin. So this is the, how are you going to give the dosing and all other information has been given. The dosage of mifepristone 200 mg orally. This is important because in 2019 they have asked the dosage as well. So mifepristone 200 mg orally, followed by 1 to 3 days later misoprostol 400 microgram, 400 microgram. 4 tablets of 200 microgram vaginally, 400 microgram vaginally you can give, and mifepristone orally you will be giving, right? So this is the preferred one. This is the preferred regimen that we have. In a patient with proliferative diabetic retinopathy, which of the following monoclonal antibody is used? So for the proliferative diabetic retinopathy, we always use VEGF inhibitor, vascular endothelial growth factor inhibitor. So earlier we knew two important one. One is known as your ranibizumab, and other there is one more bevacizumab, है ना? So we used to remember by the mnemonic like bevafarani, है ना, bevacizumab, ranibizumab, or like our ophthalmology sir, no, Shashwat sir says, and Bewakuf Rani. So you can remember that way as well. So for the proliferative diabetic retinopathy, you will be using monoclonal antibody, that is VEGF inhibitor. But there are new VEGF inhibitor as well, है ना? So again, among the given choices, Bevacizumab. Belimumab is a monoclonal antibody that inhibit the B cell activation. It can be utilized in many conditions, including SLE. SLE may you can use Belimumab. Infliximab is one of the TNF alpha inhibitor that can be utilized mainly in rheumatoid arthritis, inflammatory bowel diseases. Rituximab is one of the anti-CD20 monoclonal antibody. Don't forget, Ritu is the young girl, right? Ritu's age group is 20. So if you watch any of the monoclonal antibody wala chapter, Rituximab is always discussed, and used to say Ritu बहुत young है, Ritu is very young, her age group is just 20, है ना? Rituximab. Okay, now what are the other monoclonal antibodies? See, VEGF inhibitor में Beofarani, Beokufrani, Bevacizumab, Ranibizumab, Brulocizumab. They all are used for the same condition, है ना? They all are used for your proliferative diabetic retinopathy, है ना? Macular degeneration, age-related macular degeneration, है ना? ये इनका use होता है ना? Wet kind of age-related macular degeneration, proliferative diabetic retinopathy, we can use this, है ना? So Beofarani brought a pig, just a way to remember, right? Or Bewakuf, that sounds much better. Bewakuf Rani brought a pig. So Bewakuf will be Bevacizumab, Ranibizumab. Brought will be Brulocizumab, again a VEGF inhibitor. These are the newer one, Aflibercept and Pegaptanib. They are not monoclonal antibody, but definitely they are also having VEGF inhibitor. Pegaptanib again is a tyrosine kinase inhibitor. Aflibercept, Pegaptanib. So Beofarani brought a pig. All right, next. Which of the following agent is used in rheumatoid arthritis act by opioid and non-opioid receptor? Opioid and non-opioid receptor के लिए कौन सा होगा? So the correct answer is tramadol. Tramadol is actually a mu receptor agonist with SNARI. SNARI is serotonin noradrenaline reuptake inhibitor. SNARI, serotonin noradrenaline reuptake inhibitor. They are going to increase the level of serotonin, and they can also increase the level of noradrenaline. Okay, not the methotrexate, which is a dihydrofolate reductase inhibitor, or etoricoxib, which is a COX-2 inhibitor. Paracetamol is a COX-3 inhibitor, है ना? Paracetamol is a COX-3 inhibitor. Methotrexate is one of the dihydrofolate reductase inhibitor. So rheumatoid arthritis, can we use etoricoxib? Yes. Can we use methotrexate? Yes. But examiner is asking which is used in rheumatoid arthritis act by opioid and non-opioid. So opioid because it's a mu receptor agonist, non-opioid because they are inhibiting the reuptake of serotonin noradrenaline. So they can increase the serotonin and noradrenaline. So mu receptor agonist with SNARI, serotonin noradrenaline reuptake inhibitor. Then we have one more. Next time you can get this as well in your examination, that so tapentadol. It is actually a mu receptor agonist with NARI. Mu receptor agonist with NARI, that is noradrenaline reuptake inhibitor. Mu receptor agonist with NARI, है ना? So they will be increasing the level of noradrenaline. All right. Next, all of the following are side effect of ritodrine except. Now ritodrine, first and foremost, you have to remember it's a beta 2 agonist. They are all purely pharma question, remember, and it has been asked in this June 2022. So around 28 questions where they are pharma may. There are always 25, 28 questions that are asked in your examination. So you can not simply just take it for granted. You'll have to make sure that your basics are strong. And if you go through the class notes or the usual regular rapid revision notes that we have covered here, most of the questions you will be able to solve from here. Now ritodrine is one of the beta 2 agonists. Please remember, if they are beta 2 agonists, they will be acting at the uterus, so they will be causing relaxation of the uterus. So because they are causing relaxation of the uterus, they are utilized to slow down the premature labor, है ना? So as a tocolytic we can utilize. Because of the beta 2 activity at the skeletal muscle, Beta 2 activity at the skeletal muscle will be causing tremor. Remember, beta 2 activity at the liver, beta 2 activity at the liver will be mainly causing what? They will be causing gluconeogenesis. They will be causing gluconeogenesis and glycogenolysis. Because of the gluconeogenesis and glycogenolysis, they are going to increase the glucose level. They can cause hyperglycemia. They can increase the glucose level as well. Remember, because they are having beta 2 and beta 2 is also present on the blood vessel, they can also decrease the blood vessel tone, and there are episode of pulmonary edema as well that can be caused by this drug. Now look at this. Examiner is asking all of the following are side effect except. Let's read from down to up. Tremor. Can it cause tremor? Yes. What about hypotension? Because they are beta 2 agonists at the blood vessel, they will be causing vasodilatation. Will it cause fall in the blood pressure? Possible. What about tachycardia? Will it cause tachycardia? You see, any fall in the blood pressure, can it induce reflex tachycardia? Not only this, you also understand that beta 2 in the high dosage, they will also be acting on the beta receptor of the heart. So other beta 2 agonists like salbutamol, terbutaline, right, other beta 2 agonists that we have, they also stimulate the beta 2 and they can also increase the heart rate. They can also increase the heart rate because there are some beta 2 also present at the heart, not much, but this beta 2 agonists at the heart, they behave as beta 1. So at the high doses, they will also stimulate the beta 1 receptor of the heart. They can also increase the heart rate. What about hypoglycemia? Will it cause hypoglycemia? You see, because the beta 2 of the liver is stimulated, there is gluconeogenesis, glycogenolysis, they are going to cause hyperglycemia. So all of the following are side effects except hypoglycemia will not be seen. There will be hyperglycemia. Okay. So this was a very conceptual kind of question. To minimize the HP excess suppression, what is the correct method of administration of steroid? See, correct method of administration of steroid, whenever we do continuous dosing, there will be suppression. So textbook has suggested 3 important steps. Step number 1, to reduce the HP axis suppression. Step number 1 that has been suggested, intermediate action preparation. Don't give the long action preparation, right? Not the long acting. So long acting preparation like your betamethasone or dexamethasone, they are avoided, not the longer acting. So one step is being suggested, that is intermediate dosing preparation like prednisolone should be given. Second option is that alternate day dosing rather than giving a continuous dosing. Alternate day dosing with the same steroid. And other one is that pulse therapy with the higher glucocorticoid doses. If you are going to give higher doses, give the, we call it as a pulse therapy. So either intermediate dosing, alternate dosing, intermediate, alternate, or pulse therapy. Now let's read the option. Give at night just before the bedtime. Give on alternate days. Replace with beta. Longer acting हमको नहीं देना, याद रखना. Intermediate acting we have to give. Divide into 3 doses. They are telling give pulse therapy. Don't divide. Give pulse therapy if you want to give. So give on alternate dose is the only option that is matching our the explanation that we have. So textbook recommend, or even the guideline also recommend 3 important ways to minimize the HP axis suppression. Intermediate dosing. So there is no intermediate dosing preparation. Intermediate action preparation, they are telling longer acting preparation, like C is a longer acting, betamethasone is a longer acting. Alternate day dosing, so again B is alternate dose, so that is the correct answer here. And A is give at night just before the bedtime, no, right? So they are telling intermediate dosing should be given in the morning. Intermediate dosing in the morning, they are given in the morning, not in the night before, right? So this will be everything which were asked in our June 2022. So around 25 to 28 questions were asked, and you can quickly see that HP axis is one of the topic, then retrodinca side effect is one of the topic, tramadol tapentadol is one of the topic, VEGF inhibitor ranibizumab, bevacizumab, beofa-rani brought a pig, then MTP, medical termination of pregnancy, Parkinsonium, which drug will be causing constipation, so central acting anticholinergic drug, organophosphate carbamate, and pralidoxime will not be effective in carbamate poisoning. Remember, in a mild kind of diarrhea, we can use opioid like loperamide. chemo-induced diarrhea, also loperamide, LD50, है ना, that is a dose that can kill 50% of the experimental animal. Diabetic ketoacidosis, how will you treat? Insulin plus IV fluid. We always say ACE inhibitor, they have mortality-related benefit. Neohistamine atropine, after the snake bite, after the antivenom, this is the preferred. And I have also explained why are we adding atropine, the rationale behind adding atropine. Morphine toxicity will present to you with the pinpoint pupil, decreasing the heart rate. Remember, others are sympathomimetic here. Then we are also having hypertensive emergency. Which drug will be less effective? IV mannitol will be less effective here. Amphotericin B for the mucormycosis. Next, it is tamoxifen, which side effect, that is endometrial hyperplasia. Next is Raynaud's syndrome. We are going to use calcium channel blocker, and they have a side effect of, which drug, what is the mechanism of action of aspirin in thrombosis? So again, they are the COX-1 inhibitor. Other explanation has been given here already. Clopidogrel is a P2Y12 inhibitor, and they are given along with aspirin. We call it as a dual antiplatelet therapy. Lithium as a drug of choice in mania, always a hot topic. Cyclophosphamide, ifosfamide, in fact, anti-cancer drug important side effect, always a hot topic. Azithromycin for Legionnaires disease or for atypical infection. Warfarin will not be preferred in the first trimester of pregnancy. That is one question. Hyperthyroidism in pregnancy. Propylthiouracil, है ना. Then rasburicase is fastest to decrease the level of uric acid in tumor lysis syndrome. Leukotriene antagonists, they will not be effective in the acute bronchial asthma attack. Varenicline in smoking dependence. After the nicotine replacement therapy, we can utilize them. Then if there is a depressed patient, we are going to use bupropion. Patient with glaucoma also suffering from bronchial asthma. So which drug should be avoided? Timolol can precipitate the bronchial asthma, right? So this will be everything for this one. We have quickly revised this once again. Thank you very much to all of you. I'll see you in the next class.